We'll give it a couple more minutes till 3 o'clock, but wanted to let you know that you should be seeing the agenda on my screen now, and I believe as of now our live stream is going on YouTube. So we'll get started in just a minute or two. Thank you. Hi, everyone. This is Carly Houchin from the Kansas Health Institute. I show 3 o'clock, so I'll go ahead and get us started on our agenda for our meeting today. You should be seeing the agenda on our screen now. So you'll note this is a meeting of the Policy and Treatment Working Group. I'll provide an overview of the agenda in just a moment, but first I want to see if Eileen from the Revisor's Office is ready for the statement on open meetings.
Thanks, Carly. I am here and my light is flickering on and off for some crazy reason. I don't know what it is. Actually, I have my baby Yoda sitting on top of my light and it is literally flickering on and off. So I think he's having fun over there. This is Eileen Ma with the Office of Revisor Statutes, and due to health and safety concerns, members of the public are not in attendance of this meeting of the Special Committee on Mental Health Modernization and Reform Working Group on Policy and Treatment, but full access to this meeting is being conducted by medium of interactive communication, allowing members of the public without cost to listen to the meeting through the use of live stream audio broadcasting on the internet and teleconference as available. The live stream of this and all other working group meetings of the special committee may be found on the Kansas Legislature YouTube channel. The agenda and all other documents for this meeting have been provided by the Kansas Health Institute, and a link to the documents may be found on the Kansas Health Institute website at https://www.khi.org/pages/MHMR-WG. Additionally, this link to the document has been provided in the description section of the live stream of today's meeting on YouTube. Each member of the working group and staff will state their name and title every time that individual begins speaking or voting, so the individual can be readily identified by remote listeners. All participants are required to ensure that microphones, telephones, or other electronic devices are muted when the participants are not speaking, so that the ability of remote listeners or observers to hear the proceedings is not unnecessarily impeded. Public comment will not be allowed at this meeting. During this meeting, the committee will not recess to a closed or executive meeting pursuant to KSA 75-4319. And each motion, if any, will be clearly stated before the working group votes, and the chairperson will announce the results of the final vote. And that's what I've got, Carly.
All right, thank you so much. This is Carly Houchin again from the Kansas Health Institute. So again, everyone, welcome to the Policy and Treatment Working Group meeting. The agenda is on your screen here, so we'll run through some introductions so everyone knows who's on the line in just a moment. Then we'll move into our primary objective today, which is to review and ratify the working group report that you should have received as meeting materials in advance of our call today. So we'll go through that, and we will hit on a few key points related to the topics that were assigned to this working group by the special committee. And we will seek to make clarifying and corrective edits throughout so that we can have a product that is as strong as possible to present to the special committee. Which then takes us to our second objective in our meeting today, which is to, following our work going through the working group report, we are going to just firm up our plans for presenting those materials to the special committee later this week. So what we'll do there is we will make a plan for each of the topics assigned to this group. We'll assign someone to give the initial overview, which will be about 10 minutes running through just the high level, what is the vision for this section? What are the recommendations that the group has drafted related to that? And then what we will also do is we will have working group volunteers designated for each recommendation. And those volunteers will be people who will answer questions from the special committee related to that recommendation. So on Thursday, how I expect the meeting will go is we'll go through the working group product topic by topic. We'll start with that high level overview of each topic. And from there, special committee members, the legislative members will ask clarifying questions so they can understand more about the recommendations. And from there, we'll have working group volunteers to speak to those questions. Essentially, everyone is available. Everyone is welcome to weigh in at any point. But in this virtual format, we find it's more helpful to have someone keyed up to speak first, just so that we don't have any lag time in identifying, who the best one to answer those questions would be, and to give folks the opportunity, if they're interested, to review the recommendation and the kind of related rationale in advance and gather any thoughts that you might have regarding that. So that's what we're aiming to do today. Before we jump in to the body of our agenda, though, I want to run through some brief introductions. So the first working group member that I'm seeing on the list here, I think, is Gary.
Gary Hinault, Director of Behavioral Health Services for Youth, KDADS.
Very good. And then I'm seeing Senator Kirshen. Might be unmuted there. I'm still muted there, Senator. We'll come back in just a minute to you. Next, I see Deb.
Hello, Deb Stidham, Chair of the Kansas Association of Addiction Professionals.
Very good. Next, I see Kelly.
Kelly Hans-Reed, Director of Medicaid and Children's Mental Health for DCF.
Very good. And also Kelsey.
Hey, Kelsey Torres, Behavioral Health Consultant at KDHE.
Then Senator Petty.
Hi, Senator Pat Petty, 6th District.
Very good. And Sunny.
Hi, Sunny Mickle, Vice President of Government Community Relations at Blue Cross and Blue Shield of Kansas.
Very good. And Senator Kirshen.
Okay, I think I got it now. Can you hear me?
Yes, we can.
Okay, thank you very much.
All right, so I think that is all of the working group members on the phone, unless I've missed someone. Scanning the list, not seeing anyone. Okay, so I will go ahead and start my screen share here. As I think I said as we were opening up the meeting, you all should have received a copy of the draft working group product in advance of this meeting. It's also posted online at the link that Eileen mentioned for us in the overview. So mention that for you just in case it's more helpful to have control of your own document as far as what you're seeing on the screen. I have a few items flagged here for your specific review. But beyond that, again, we're just looking to make any clarifying or corrective edits so that we can put forward a strong product for the special committee later this week. So to start with, the first part of the product that I wanted to check in with the working group on is this report overview. So there's a couple of specific things in here that I would like some feedback on, but would like to first ask for any high-level comments on this overview portion. If you had a chance to review, is there anything missing or anything incorrect that you would have us address at this point? And for those who are getting their own version open on their screen, this is kind of considered some of the front matter of the report. So it's on Roman numeral page 3. Okay. One of the specific things that I wanted to flag for the group is that we have included a definition here in this box of behavioral health. That was included due to a request, and I'm forgetting if it was in a working group setting or at one of the special committee meetings, but there was a request to include a definition of behavioral health so that we could be sure that everyone was using consistent language as to what we were referring to as behavioral health or mental health, and where substance use disorder fell in with all of those terms as well. So the language that you're seeing here is very slightly adapted from the definition provided by SAMHSA, and was identified in collaboration with KDADS, the state mental health agency. Any questions, comments, or edits on that definition we've put forward there?
I think it's a great definition. Deb Stidham.
Sounds good. Okay. Then the next item in the report overview that I wanted to flag for this group is some of these vision statements. So as a reminder, the 3 topics that were assigned to this group by the special committee were prevention and education, treatment and recovery, and special populations. So you should see those on your screen now. And the goal with these, so if you'll recall, kind of throughout the special committee meetings and in the working group setting, some as well, we've really worked to articulate kind of what we mean when we say modernization related to each of these topics, so that it's clear the recommendations are kind of more detailed action steps to get towards modernization, but having that end goal in mind is the aim in some of these visioning statements here. So would be happy to hear any clarifying edits or comments from the group related to the statements drafted here related to prevention and education, treatment and recovery, or special populations.
This is Deb Stidham again. I would like to include the word behavioral health in there. I mean, I know it's implied, so it might read: modernized prevention efforts will seek to meet the needs, to meet the behavioral health needs. And I don't know about special populations. If you look at universal prevention, that's targeted toward the whole population, of populations at increased risk for poor outcomes requiring collaborative trauma-informed approach and appropriate funding. I would just take out the to prevention.
Okay, this is Carly at KHI. I was making changes while you were talking there, Deb. Those look okay?
Well, it's good.
Great. Any other comments related to, well, first, any concern with those edits there from working group members? Okay, seeing shaking heads. Any other clarifying edits related to either the treatment and recovery vision statement for modernization or the special populations vision statement? Okay, not hearing any. Also want to flag for this group, there is a visioning statement here for the telehealth topic. So as a reminder, for the topic of telehealth, a subgroup was formed with members from all 3 working groups. So I'd primarily be looking for feedback from those who participated in those conversations, just to make sure we're capturing the intent of that group that came together. But we'll put the telehealth visioning statement on the screen here briefly as well, just to see if there's any clarifying edits.
Deb Stidham again. I guess I live and work in an urban setting, and I am seeing the value of telehealth. So while I appreciate the value for the rural and frontier, I guess it does say urban. Never mind. I didn't see that word. I was thinking that it could say just meaningful access to care in particular the rural and frontier, but just forget what I said. All right.
Sounds good. Okay, not hearing any other edits there. Another item in kind of the front portion of the report before we get to the topic specific items for this group is the data profile. So this was put together, you may have noted if you've participated in some of the special committee meetings in particular, an interest to be sure that we are measuring outcomes and using that to inform how decisions are made around funding and other issues related to behavioral health. As a first step, and this is very much a work in progress, as a first step towards identifying some of those measures that will be important for understanding kind of the health of the behavioral health system. A couple of folks on our team at KHI worked with some of the state agency staff to understand what data are currently available related to kind of some of the key components across sectors in the behavioral health system. So that's what you see here in this data profile section. And I will say it should be a bit more populated from the version that you received in the PDF, as we've been kind of tracking down the data as we receive it. But again, this is something that's a bit more of a work in progress and that we expect to evolve as future groups take up this work.
Carly, this is Gary from KDADS. Where in the document are you looking at?
Yeah. So it should be page 5 in the PDF, assuming I don't think that would have bounced too much as we've made edits from other working group meetings.
Thank you.
Mm-hmm. So the idea with these measures is that they would be something that could be reviewed to get a kind of a high level sense of the health of the behavioral health system. So a variety of outcome measures listed here, as well as some ranked measures from the Mental Health in America report that's available on, I believe, an annual basis. One specific question I would pose to the group, and I apologize for some quick scrolling back and forth on this. We are still working to find some measures related to substance use disorder that would be appropriate for the purposes of this data profile. So I do wonder if the group has any specific suggestions on that front.
SAMHSA has what they call the NSDA, the National Survey something household.
Mm-hmm.
So, it's not, the last I checked, it'd probably be 2014, 2015 maybe, but there's definitely there will be Kansas data around need for treatment, receiving treatment, that kind of thing. Is that what you're wanting?
Yeah, that's helpful to know. That,
okay.
That's the source that others on the previous working group earlier today flagged for us as well.
Okay.
But helpful to hear those specific measures within that would be of interest, Deb. So thank you for those comments.
Do you need anything from me? Or are you going to find it?
I think we can find it based on that description because, yeah, I know we know what source you're referring to there.
Okay.
Okay. So again, we expect this data profile to kind of change and evolve as this work continues, as this is kind of a first pass at identifying what might be measures that are particularly meaningful and kind of making sense of how the overall behavioral health system is doing.
Carly, this is Deb. I have a question.
Yeah.
I saw one measure about workforce. Is that considered sufficient or what?
So this is Carly at KHI. We can certainly add other measures. The other thing that I was just getting ready to flag for the group is that, so there's this data profile here, and then throughout the report, in the body of the report related to each recommendation, we've identified other measures where they might be like particularly responsive to a recommendation that a group has put forward. So there's 4 or 5 recommendations on the topic of workforce, and I believe there's a handful of measures there related to workforce. That being said, we can definitely pull some of those up if we think that is an issue that should be, that needs more representation at this kind of high level. Okay. Unless there are other questions on the data profile, I'll take us into our first topic specific section of the product from this group. So that begins, I believe, on about page 21. And then the first recommendation that we see will likely be on page 22 if you have the PDF open. So what I'll do here is I'll run through all I think 4 of the recommendation handles here, just to remind everyone of the recommendations we're looking at here. And then any, again, clarifying or corrective edits on any of them are welcome. So the first recommendation related to this topic of prevention and education, recommendation 4.1, is related to the 988 Suicide Prevention Lifeline funding. Then recommendation 4.2 has to do with early intervention. Recommendation 4.3 has to do with a centralized authority for coordination of behavioral health. Recommendation 4.4 has to do with behavioral health prevention. And those are the 4 recommendations in this section of the product. So any clarifying or corrective edits from working group members on any of those 4 recommendations or related rationale? The rationale should largely be reflective of either the discussion of this group or where the recommendation was pulled from one of the past reports we started from. Then we pulled forward the supporting information from those reports as well. So if there are not, I didn't receive any edits or questions in advance on that section. So if there are not questions there, I can move us to our next topic.
I have one thing for consideration regarding the centralized coordination of behavioral health. This is Deb Stidham. So the second part of that, policy and provider education, that's a little bit narrower than I think what I had in mind. So maybe coordination might be a better word.
Okay, I can make that edit here. We'll open that up to working group members to see if there's any questions or concerns on that edit. Okay, and Deb, would that require, I'm doing a quick scan of the rationale here, would that require any adjusting of the rationale to better reflect the intention of the group here?
I don't think so. I think the rest of it kind of captured what we were talking about.
Okay. Very good. Then I'll move us to our next section. So treatment and recovery is the next topic assigned to this group. So on the PDF, that should begin on about page 25 with the first recommendation on page 26. Again, I'll just run through the handles of the recommendations here to remind everyone of kind of what we were talking about in this section. So recommendation 5.1 is related to PRTFs. Recommendation 5.2 is related to the service array. Recommendation 5.3 is related to frontline capacity. Recommendation 5.4 is related to housing. And those are the 4 recommendations on this topic. Any clarifying or correcting edits from working group members on those 4 recommendations?
Carly, Brenda Landwehr here. Can you go up to the housing one for just a moment, please?
Sure. So the housing recommendation for those in the PDF, I believe is on about page 29, and have that on the screen here.
Okay, thank you.
So I did have a question flagged here for discussion, particularly in the rationale. We wondered as we were going back through and reviewing this, if we missed anything about transitional services related to this housing recommendation that the group would want us to add here.
Brenda Landwehr here. I don't know what we would have on a transitional, but there probably are some steps that should be taken. So I'd have to rely on the folks out there that deal with this on a regular basis to give us an idea of what those recommendations should be.
Mm-hmm. Yeah, I wonder.
It's not a matter of just supplying housing.
So I wonder if Gary or Kelsey or Kelly or other working group members, but I'm thinking particularly those from the state agencies, might be able to help us clarify if it would be helpful to add a piece in this rationale about transitional services, or is that implied with the programs we've referenced?
This is Kelly from DCF. I don't have strong feelings or knowledge on this, but when I think of these programs, I do think transition planning is included in that. That's just off the top of my head.
Great, thank you.
Gary from KDEDS, and certainly my expertise is more with the youth programs. So this would be more affecting, I think, the adult programs. I do believe within SOAR it connects them with several different programs. I would have to check with some of my staff really to be able to give you a good answer on this. Sorry.
Okay. No, that's helpful. Honestly, we were just wanting to make sure as we were writing the rationale that we didn't miss an important part of the intention of the group. So I'm not hearing from the group that the transitional piece it might be tangentially involved, but it doesn't, from those initial comments at least, it doesn't sound like something that's a core piece of what this is that we've totally missed here. So the other question that I had flagged for still related to the same recommendation 5.4 on housing. So you may have noticed as you moved through the review of the report, where possible throughout, we flagged the action lead. So the agency, go ahead. So throughout the report, we flagged where there's an identifiable action lead that should kind of take point on implementing a recommendation. But what we've also attempted to add throughout, and again, this is where we relied upon past reports, we had tried to identify key stakeholders who should be involved as the recommendation is implemented. So basically, like, this recommendation should not move forward without input from X, Y, or Z entity or stakeholders or impacted individuals. We struggled to identify who that might be for this recommendation. So I did wonder if any working group members could provide insight as to who would be kind of important collaborators for moving a recommendation like this forward into implementation.
This is Deb Stidham. Do we want to include the homelessness subcommittee of the Governor's Behavioral Health Services Planning Council? I would presume that that is already comprised of different folks from the different sectors that help to inform that group's recommendations. So that would at least be a start. And then, you know, the Association of Community Mental Health Centers, Kansas Association of Addiction Professionals, certainly representatives from those groups.
This is Gary from KDADS. I think we'd want to put KDHE in there also, because that would be a lot of the Medicaid, possible Medicaid billing. Not only in that one, but I was looking at some of the others, and maybe we need to put KDHE in a few of those too.
Mm-hmm. So Gary, could you flag some of those for me specifically so I can make that note?
Specifically in this group, I think the 5.1.
Okay.
5.2. I don't think it would hurt to have it actually in 5.3 either. They're the lead agency, so.
Hey, Gary, would there be in some of those places too, KDADs, because of dealing with the older population on the Medicaid?
I think it probably could, yes.
Because I know people get confused that they think that because the Medicaid director sits with KDADs or KDHE and a lot of our programs run through there, KDAD still has a large piece of stuff they can do with Medicaid.
There's a lot of program, yeah.
So confirm that KDADS is referenced throughout. The only place where KDADS isn't listed, I think, is the one regarding frontline capacity. I guess I'd pose the question to you, Gary. Do you think should KDADS be listed as one of the key collaborators there, or not?
Which number is that one?
5.3, frontline capacity. So where I'm looking at, it's on page 28.
Yeah, I got it. Let's see. I think KDAD should be in there when I think about the different, several different commissions.
Very good. Any other questions or comments from working group members on any of the treatment and recovery recommendations here? Okay. Not hearing any, I'll take us to our third topic here, which is special populations. That should begin on about page 29 with the first recommendations on page 30. So the first recommendation here was related to domestic violence survivors. The second one, recommendation 6.2, was related to parent peer support. Recommendation 6.3 was related to crossover youth. Recommendation 6.4 was related to IDD waiver expansion. And recommendation 6.5 was related to family treatment centers. So same questions on the table. Any clarifying or corrective edits across those 5 recommendations?
Carly, this is Kelsey with KDHE. I'm going to keep looking through this, but I would say for parent peer support, which is 6.2, KDHE should be included as a key collaborator.
Great, thank you, Kelsey.
I was thinking exactly that. This is Gary from KDADS. I thought the same thing, Kelsey, but I also wondered about 6.1.
Are you thinking like the public health side of KDHE?
Public health and then the whole policy and treatment. I mean, just, if we're doing things that are going to be adding to policy, KDHE always seems to come to mind with anything related to policy.
That sounds great, Gary.
So this is Carly. I'll also note throughout, there are several places on this measuring impact field where we currently have a TBD. In some of those cases, we still have pending questions out to various agencies to try and identify what might be the most appropriate measure. But if anyone on the call has any thoughts on filling in some of those gaps as well, that's something else to, you can provide feedback if you're interested to do so. Any final comments on this section?
This is Kelsey with KDHE. I would say KDHE needs to be included in 6.4.
Okay. Added that there.
Possibly in 6.3, like if we're looking at Medicaid policy, then definitely.
Okay. Not hearing any other edits, then I think I'll take us to the next item for review, which is the telehealth, the work from the telehealth subgroup. So here, primarily looking to hear from those who participated in those a couple of subgroup calls, just to make sure that we maintain the original intent of that group. But I'll run through the handle of these recommendations and then the ask is the same. So clarifying or corrective edits throughout. So for telehealth, the first recommendation was related to quality assurance. The second recommendation was related to reimbursement codes. The third recommendation, 10.3, was related to telehealth for crisis services. Telehealth recommendation 10.4 had to do with originating and distant sites. And telehealth recommendation 10.5 had to do with the child welfare system and telehealth. So any clarifying or corrective edits across those 5 recommendations?
This is Kelsey with KDHE. I'm curious, I noticed on 10.2 that the action lead was listed as KDHE Division of Healthcare Finance, which I think is fine. I was just curious about consistency across the document. Do we want to distinguish between our Division of Healthcare Finance and Public Health, or do we want to just do KDHE?
This is Carly at KChat. That's a good question. I was kind of just thinking about that before. I think we clarified here, since it's so specific to the Medicaid program, that it was very evident. But I would say generally throughout, we haven't been any more than agency or organizationally specific here. So this one is maybe a little bit of an outlier because it's really clear that the work will need to be headed up by that group. But if the working group, if you all feel differently, that it would add clarity to add some of that detail elsewhere, we can certainly drop that in.
Hey, Carly, this is Sunny Mickle from Blue Cross and Blue Shield of Kansas. When you're done with that, I would like to go back to 10.2 if possible.
Okay, 10.2.
Yes. On this section with reimbursement codes, I know we discussed this quite a bit too. But under the rationale, one of the focus areas seems to be on that originating site fee. And as I'm seeing it listed here, I think there's some confusion about what the originating site fee is for, that facility fee payment. It seems like it's backwards in some ways, because at the end of that paragraph, it says services provided to patients in their homes do not receive a facility fee payment for the originating site. The originating site is where the patient is located.
Yes,
So-
and there was extensive discussion on this, and as I'm remembering it, I think this was intentional on behalf of the group, because the early in the COVID-19 pandemic, the CMHC in the service area in which the patient resided, that the patient would have been affiliated with that CMHC, they were providing almost, I think, like technology support to patients in their home. And that was taking staff time. And I think there was I believe the intent of the group and other working group members who participated on that subgroup, please correct me if I'm wrong. I think the intention was to allow that to be originating site facility fee to support patients as they receive services in their home, to allow for them to receive the necessary technology support from that entity. I don't, that wasn't a very clear explanation. That's my recollection of how the group discussed it. But again, would welcome comments from others if A, that was about as clear as mud, or B, if I am misremembering here.
No, I think you're remembering it correctly, from understanding that. But in not every situation is a patient receiving, say, a cell phone or a tablet from a provider so they can use that back and forth. I think that's almost something that is necessary to create a different code for in those situations when that's happening. But to add that on to every service actually inflates the cost of the services and takes money from the system overall, when the intent of that originating site fee is, for example, when you have a facility that actually has a patient coming into the facility, the patient sitting there in a private room that no longer can be used for other patients, and they're working with that patient directly on site to connect them to a specialist or a provider that's sitting at another spot and providing that service. So that was really the intent of that from the insurance perspective. And for reimbursement, it acknowledges that. So I think it's a significant problem actually to add that on to every service if the patient is at home, because that the reason for it is really not there. It's not as necessary. And it always, unless someone's actually, again, getting a tablet with internet coverage, that's very different. And I think it needs to be a different type of code.
Okay. Could you help us suggest a clarifying edit here so that we maintain the intent of the group in wanting to capture the time for that, for example, the CMHC that would be providing that support so that there is meaningful access to the telehealth service? Could you help us with the clarifying edit there?
Certainly. I'm just thinking services provided to patients in their homes do not receive a facility fee payment for the originating site. However, in situations where technology support is provided to patients, consideration should be given for provider technology assistance.
Okay, Brenda Landwehr here. Let me ask you, Sunny, if I'm understanding you correctly, there's a difference between the example you gave of going to a CMHC office and connecting. Then there's the issue of perhaps being provided a tablet that you would then take with you and then get services at home. Is that what you're looking at?
Yes, I think it's very different how
Yes.
significant the additional services and support actually are. Because in a facility setting, when they're getting the facility fee, that is because then you're using the internet services and the other technology, the tablet, computer, whatever, even a nurse assistant or someone is actually helping you set you up to receive the services from the distant site.
Okay, so then is there an incidence where you would also, instead of having to come into the building, to a facility, would you be given hardware like a tablet that you'd take home and then you could get your mental health services in your own home? Or have I taken it a step further than what it should have gone?
I don't think that happens in every situation today. And I know it doesn't happen most of the time, but I
Okay.
think there are some providers that may be trying to find those avenues to maintain access to members that are in situations and have difficulty with internet and such. In most cases, though, tablets and other devices are not provided.
Okay, I think that we want to be real careful because I can see this as a potential path down the road where there may be providers that want to do that, and we'd have to make sure that we clarify what you're talking about, Sunny, on the coming into the facility, and that if any hardware or whatever to do these services at home is a separate coding issue, correct?
Correct.
Okay.
And this is Gary from KDEDS, and what I remember is also the idea, it says IT support, patient education or preparation. So I was really thinking that part of what they were saying is, do we, needing to help the patient or family set up or have the contact or teach them how to use services from home. What preparation do they need to be able to make use of those services? They need someone to call and say, this is how you get logged in.
So this is Carly at KHI. I was drafting some language as Sunny was speaking there. So that's on, I went ahead and just made it in the comments since we're still kind of workshopping it. So part A of my question is check my work here. And then part B, I think we need to, I'm not sure what to call the entity that would be providing this support, because it seemed like calling them an originating site was maybe going to be a little bit of a hang up. So those are the two parts of my question. The statement that I had drafted from Sunny's comments was, however, in situations where technology support is provided to patients, financial consideration should be given to something like an originating site, but it's not in their facility. So maybe that language doesn't work. When a patient requires technology support.
Carly, let me ask this question here. I think that we, and anyone else here that wants to jump in on me on this, is I think that we are about to, or we kind of have opened up a real can of worms that, and if we don't get this wording just right, it can be a problem going on in the future. So perhaps it's something that 2 or 3 of our people, along with you, could work on that. Unless they think they can come up with the wording now, that's going to have to be very precise or we're going to be in trouble.
Mm-hmm.
And then what could happen, they could send that wording to you and then you could just disseminate it to us and we say, yes, add it to the report later on this afternoon. Would that be workable or not?
Really, the only thing that we're up against here is the timing. Just
Right.
Yeah. That's my only
This
struggle.
is Senator Petty. Could it be as simple as just saying given to the provider?
No, I don't think it is, Senator.
I was trying to think of, this is Gary from KDEDS. Okay, so the originating site would be, that's where it is, but we're talking about if I, as a CMHC, am giving IT support to the family. And that's why I think where Senator Petty's coming from in the sense of provider, but I was trying to think of what other term we would use for all of the folks that might to assist with that appointment.
This is Carly at KHI. I'll pose the question back to Sunny to see if you had a language suggestion just to designate what we could call that entity that would be providing the IT support, patient education and preparation. If they're not an originating site, is there an appropriate way to refer to them?
I don't have a term or an actual definition that we could use at this time. I really would have to look into that a little bit more, and I could definitely get something back to you later today that we can.
Okay.
Would it possibly be service provider? So we're saying the person who's providing the service is having to provide the IT support. I don't know.
Mm-hmm.
Hey, Carly, this is Brenda Landwehr. I just see us going down a path on this here that we can't afford to take. How difficult would it be, Carly? Okay, you guys go ahead and prepare your report, because this comes to us on Thursday. Then in between now and then, we could have Sunny and Gary and whomever else wants to, maybe throw some things back and forth, and they could come with wording to us. And then in the full committee of legislators, we could add this to the report. Would that be accurate? A change?
Yeah, this is Carly at KHI. If that's something that you want to have flagged for specific discussion in the special committee when we get to this issue, that would give us more time to kind of workshop language here. And also we'll kind of have more of the telehealth subgroup, on the call then, so we make sure we don't lose the original intention there, including some of the supplemental experts who joined from the telehealth resource centers.
Okay. Because the complexity comes is whether you're dealing with insurance codes or Medicaid codes, there's always a fiscal tie to it. And if you're not, specific, it just creates a problem, an unanticipated problem, and we can't afford to do that. And I would rather people have time to, come up with the proper terminology to the best of their ability, and we make that change then before we submit the final report.
Okay, so this is Carly at KHI. I think gonna reflect back, so I make sure I know all my action steps there. I'm gonna drop in this statement that we've drafted with Sunny's help. I'm just gonna use the generic service provider term for now. However, in the special committee, in my kind of facilitation notes of the questions we need to be sure to address, I'm gonna have a tag next to 10.2 to make sure that we're really clear exactly the mechanism by which additional reimbursement options would be available to make sure we're not opening up something wider than would be intended. Does that sound like the plan that the group has landed on?
Yeah, so Brenda Landwehr here, I think that's where, Sunny, I just got to give you a project.
That is okay.
Yeah, but it's a very important piece of this project, and I think you and Gary definitely understand it, and probably some others on here, but I know just enough of it to be dangerous, and I can see the concerns.
We'll work on that. Thank you. I'll connect with Gary too.
All right.
Thank you.
Great. All right. Thank you for those really helpful clarifying discussion there. Other recommendations related to telehealth that we need to make clarifying edits on.
This is Deb Stidham. Can I just make a comment about, and I wasn't on the work group, but I noticed a bullet about opening up Medicaid codes to deal with, that talked about, yeah, you're getting there. It's at the very top there, right there. So when measuring impact number of telehealth crisis codes open, Medicaid reimbursement, utilization of those codes, but we're also talking about law enforcement and mobile crisis services. So I just want to point out that I would say in a very large percentage of the time, these are not open clients to anyone. So and they probably aren't even Medicaid eligible. So, I mean, I guess utilization kind of covers it, but I just wanted to make that point.
So this is Carly at KHI. Is it helpful? So the places in the report where we don't have measuring impact statements or items to drop in at this point, I'm gonna go through once we have the final word on all of those and say something to the effect of additional work is needed to have a measure to appropriately capture the impact, something to that effect. Would you like me to add that here to clarify that a lot of the individuals in crisis would likely not be Medicaid beneficiaries?
Yeah,
Okay.
in particular, because you have the action lead is KDHE. So again, I think there's just a presumption that whoever's providing that crisis service can run back and build that code, and that's probably not going to happen.
This is Gary from KDADS. The other thing to think about for kids, I know we currently have DCF has a RFP coming out related to mobile crisis. And I think there will be, hopefully in the future, some adult mobile crisis coming out. So that's going to entail quite a few changes. And so I think that we should make sure we also have DCF on this as a key collaborator, right there. But I think it's something that, as Deb was saying, is not really current, but it is something that we're hoping to certainly get out there, and that those crisis services in other states, as recognized in here, they have developed ways of using Medicaid codes to get those things covered. So, and having people services become eligible pretty quickly. So there, it is basically talking to some major changes.
Okay. This is Carly again at KHI. I'll maybe make last call, additional changes that we need in this telehealth section. Okay. Not hearing any, then I'll kind of ask the group to zoom out and kind of final call across the product. Are there final, either again, clarifying or corrective edits that you'd like to take us back to? Okay. Not hearing any. This is the last portion of the report that I had flagged for our specific review. So if there are no kind of overall comments, at this point, we'd consider this product ratified on behalf of this working group. So want to thank you guys there for really the hours and hours of work that you have contributed to this in terms of sharing your expertise so that we can have hopefully a slate of recommendations that make a lot of sense and are really clear to implement. To get to that point though, the second objective for our meeting today is to make sure we have a really strong plan in place to essentially pitch these recommendations to the special committee. So to do that, what we're going to do is run through each topic. We'll need a volunteer to give a brief overview of both the vision statement that we briefly discussed in the report overview, and then run through the kind of briefly describe the 4 or 5 recommendations related to that topic. So I'll need one working group volunteer for each of these topics, and then also would like a volunteer for each recommendation so that we have someone prepared to jump in to take any questions that the special committee has related to that topic. And again, anyone's willing or anyone is welcome to jump in wherever. But if we can have someone kind of queued up to speak, that can keep our conversation moving. And that way we'll always know exactly where the expertise is on an issue. So
hey, Carly, this is Gary from KDADS. Do we have any kind of timeframes around when these will come up in the conversation?
So we have allowed, I think, the tentative agenda has about 30 minutes per topic, and it'll start with working group 1. So go, 30 minutes, an hour, hour and a half. So that would put probably about 10:45. We would be getting to prevention and education. That being said, it's a little bit hard to estimate precisely how much time would be needed. So I'd recommend, if you're only able to join for part of the day, one, I'd be happy to kind of shoot you an email as to where we are in the timeline of things. Or two, I'd recommend probably like the 10:30 range joining, so that you can be sure to be on by the time we start the prevention and education discussion. So that would put prevention and education at about 10:30, treatment and recovery at about 11, and special populations at about 11:30.
So are we thinking it would all be covered on Thursday?
Mm-hmm. So Thursday, pretty much the whole day, we'll be providing an overview of these recommendations to the special committee and taking questions. And then the special committee will be kind of doing their work to prioritize or get to their final product on Friday. With the exception, they have a 1-hour block in the morning on Friday to take any kind of new questions that have come up overnight. So the ask to this group would primarily be on Thursday.
Okay.
This is Kelly from DCF. What is the date? I don't even.
That is this Thursday, so December 10th.
I don't think I have an invite for that.
I'll make sure.
But
I'll
maybe
make sure
I
that
don't have to go. I don't know. It depends.
I don't want to let anyone off that easily, and certainly don't want to leave. Really, this is the opportunity for the special committee to understand all that went into the discussion to arrive at these recommendations. So to the greatest extent possible, if we can have working group members there kind of ready to make the case for why these items were prioritized and kind of what their contribution is to modernizing the system, that will likely inform how the special committee gets to their next steps as far as the 2021 legislative session.
So the ask would be that we'd give this is Gary from KDADS, a synopsis of the recommendation.
Mm-hmm. Yeah, so sorry, just to jump in there, here's how it will work related to each topic. So we'll start with about a 10-minute overview of everything in the prevention and education topic. I need one volunteer for that. And then I would have just names penciled in next to 4.1, 4.2, 4.3, 4.4. And those names are just in case questions arise related to that recommendation specifically. Our facilitator day of would know that, Kelly's going to be ready to jump in related to the crossover youth recommendations or something like that, just so we don't kind of waste time there. And to give folks the chance to kind of look back over the recommendations and gather any thoughts that they might have, or even just, make sure they've reviewed the rationale so they remember the discussion that the group had around it. So hopefully that approach seems clear to you all. Do I have a volunteer to give us that brief overview of the prevention and education section? So this would be describe the vision statement there and just briefly walk through the 4 recommendations in about 10 minutes.
This is Deb Stidham. Of all the categories, I probably, could speak mostly to these, though I will say up front that the suicide prevention line and to some degree the early intervention, not really my wheelhouse. So I'll be out of my depth pretty quick.
Yeah, and one, Deb, really appreciate you jumping in to volunteer there, and that's really the value in having working group members toss their name in next to specific recommendations so that they can be maybe at least the first person to speak as there are follow-up questions related to those.
Sure.
So
this is Gary from KDADS. You could put me in on 4.1, the prevention, the 988 suicide prevention line.
Great. What about 4.2 around early intervention?
You can certainly put me down for that one too. Then I'm going to remain quiet. No.
Sometimes if
Kelly
you
should
just
probably
leave
be
it.
in. Kelly should probably be on that one too.
I was thinking.
Yeah, go ahead.
Okay, I'll drop a couple of names where needed, because it's always helpful to have more expertise rather than less. Deb, am I remembering correctly that the centralized authority recommendation was one that you were interested
I
in?
figured for sure I was going to get tagged with that one.
Okay. What about the recommendation 4.4, behavioral health prevention? Any volunteer to take any questions that might come up there?
I can do that one too.
Okay, then moving us on to the treatment and recovery topic. Do we have a volunteer to do the brief overview of the vision statement and then the kind of high level pass over the 4 recommendations here?
So the vision statement is right. It says treatment and recovery, and it's right under that paragraph or so right there.
That's kind of a little bit more of a.
Do we already have a vision statement, or are you wanting us to come up with a vision statement?
We already have a vision statement. It's in that report overview section. The treatment and recovery, that longer paragraph, it's the same information. We just weren't as concise there. We had a little bit more space. So the treatment and recovery vision statement is up under report overview, and that's on Roman numeral page 5.
Roman numeral page 5. Okay. Well, I think that this area seems to fall in my mostly.
Okay.
And certainly me for 5.1, 5.2.
Kelly, do I remember correctly that you weighed in quite a bit on the service array as well?
Yep, you can put my name down too.
Okay, 5.3, frontline capacity. Kelsey, are you still on?
Yes, I can be that person.
Yay.
Okay, and recommendation 5.4 related to housing. An option that I didn't pitch earlier, if there's anyone on the working group who's not on this call that you'd like to volunteer, I'm happy to shoot them an email and coordinate offline. Which I will say, Gary, one of the other working groups did, they volunteered you to answer questions related to the family engagement plan.
Oh, that's nice.
I'll send you an email with more information.
Well, I'm wondering if some of our housing folks from KDEDS are on a different committee, whether that's Misty, Boston. Kelsey, you can help me because I always mess the names up.
I don't think there's a Misty on any of our working groups at this point.
Or Melissa, Boston, Hastings. I always get that wrong.
We can go ahead, Kelsey.
Sorry, I was going to say there's Misty. I think it's Bosch Hastings.
There you go.
Melissa Bogart Starkey. I think.
Yes.
Housing with KDEDS.
I don't know if either one of those people are on. So we really need committee members, huh?
For the most part.
This is Kelly. You can put me down. Give it my best shot.
Okay. So that takes us to our third topic here, special populations. Looking for a volunteer.
I can take that. This is Kelly from DCF. I'm sorry. Can I just confirm one more time? When is this meeting? This Thursday.
This Thursday, December 10th. And I expect that I think we'll get through all 3 of your topics in the morning portion of that meeting. And I'll send the Zoom link that we have from KLRD out to the working group members if you have not already received that.
It's like all morning.
I'd have to pull up
9 to 5, I think, the whole thing.
Oh, okay.
9 to 5 is the whole thing. But yeah, so I think working group report outs probably will start around 9:15 and then go about 30 minutes per topic.
Now, I got excited because the agenda says 3:30 adjourn.
That
even
very
better.
well might be the case.
I can
So
help
then,
with point 2.
okay.
Same. I can do all of it. Well, I can help with all of those.
I have a question. This is Deb Stidham about the recommendation around family treatment centers. I think maybe that was discussed when I wasn't present. Is that an expansion of the designated women's treatment centers for substance use disorders, or is that a broader recommendation?
It's an expansion.
So it's something more than,
Well, we put in there, I think we put in there more than just women. That we put family members.
Mhm.
It could mean dads.
sure. But that's the model you're looking at.
Yes.
Okay.
So then,
Deb, would you be able to help with that one?
Yeah, I could certainly
I can
speak
add to it and talk to them about the importance of.
I can talk about the current capacity around that and where it comes from.
very good. So this is Carla at KHI. I wanted to confirm, I don't know that I heard a volunteer related to recommendation 6.1.
I can do that one. This is Kelly from DCF.
Okay. Very good. So we'll have Deb provide the overview related to prevention and education. Again, about 10 minutes, hit on that vision statement review, and then just the initial high-level pass over the high priority recommendations in that topic. And then Gary will do the same for treatment and recovery, and Kelly for special populations. And then have folks assigned out here to be, again, there's nothing to prepare necessarily if you've signed up for one of these specific recommendations. Again, it's just helpful to have someone as the kind of first person to call on related to each recommendation, so we can keep the conversation moving. And if you're interested to, I would recommend to take a look at the rationale table that we have related to each of those, just to refresh your memory on the nature of the discussion. But if you have any other questions as you kind of gather thoughts or whatever, please feel free to send me an email.
And Carly, could you, I know we went through that kind of quickly, but could you send just this synopsis out as to who said they would do what?
Yes, I'll send that. I'll send that along with the Zoom meeting entry information to make sure that all of the working group members have that, so that they can, log on to participate on Thursday.
Great.
Okay. Any questions that I can answer at this point? Okay. Not seeing any then. I think this actually takes us through everything we were hoping to accomplish today. We have a ratified report. We'll, a couple of the places throughout where we left comments, we'll iron out that language. And then what you can expect as far as next steps, the cleaned up version of the final report will go out to the special committee and to all working group members tomorrow afternoon. So we'll get these tidied up tonight, get it to our communications team tomorrow so they can turn it back around and send it to you all tomorrow afternoon. So you'll have the clean final version for the special committee meeting beginning on Thursday morning. Okay. Well, if there are no other questions, then we have accomplished what we came to do here today. So thank you again, everyone, for not just your contributions today, but throughout the work of the Policy and Treatment Working Group. Definitely this report could not have come together without all of your substantial expertise. So really appreciate your contributions, and looking forward to talking with everyone again on Thursday at the special committee meeting. We're adjourned.
Thank you, everybody. Thanks, Carly, for keep us moving.
Yeah.